This is very important throughout the course of life. Our appetite control center lives in the hypothalamus. When patients have neurological disorders, their skills for feeding, chewing, swallowing, all those can be impaired. And feeding can be affected. Also, we have to consider that neurochemicals that are present in the brain are going to impact the GI tract, including motility as well as sensation and all the digestive functions. So that is something really important that we take into consideration with patients that have chronic conditions. Nutrition support, it is something very important for our patients, and providing support not only for children but also for older individuals with chronic medical conditions is key from the medical standpoint. We want them to optimize health, their functional status, and also improve their quality of life. Ultimately, that is our goal. With children, we have another bigger challenge, the fact that they are growing, and that is a very important function, and a function that needs a lot of calories and a lot of nutrition to accomplish. So that is a very important thing for us during this process. Individuals, and particularly children that have chronic medical problems, are going to face a number of challenges throughout this process. Those include issues such as fatigue, oral aversion, where they don't experience the same enjoyment or pleasure as we typically associate with feeds. Issues with oral aspiration, where feedings don't progress in the GI tract the way they are meant to be, and they end up in the respiratory system. This can happen silently, but it also can happen in association with symptoms, and that becomes a challenge for them. For many individuals, there's an imbalance between their ability to consume calories and the amount of energy that they need to spend in order to feed. There can be some other issues that will affect them, including severe reflux symptoms. They can experience gastrointestinal dysmotility, and some common problems include a slowed stomach emptying as well. In children, we face these challenges, and we have some options in order to be able to provide nutrition support for them and help them grow. One of those tools is a G-tube or a G-button, and that will help meet those goals. There are several reasons for which we consider a G-tube for nutrition support. Some of those reasons include poor oral intake, children that demonstrate feeding difficulties, coughing, gagging, increased congestion, color changes associated with feeds, significant fatigue. There are other children that just experience a slow, poor weight gain when we monitor them and follow them through their growth charts. In other cases, we had seen issues with weight loss. Also, there are cases in which very special types of formulas or diets are necessary, which are very poorly tasting. Therefore, it is very difficult to get them to consume those amount of calories orally. Also, when we consider children and individuals that need a nutrition support that extends beyond a 6 to 8 week time period, those are situations in which a G-tube actually becomes a really good option in their care. One of the things that we know, and as physician and as part of a medical team, we understand and take into consideration is the fact that this is a very important but very difficult decision for many families. And we understand every family has different circumstances and different reasons why this is an option that may be a little challenging for them. One of the things that I want to emphasize is that this is a team effort. So we have a group where everyone in this team, which includes family, physicians, nursing, dietitians, occupational or speech therapists, child life specialists, social work, and home care companies have a different area of expertise and a different role as they participate in this process. So families are not alone here. We have a group that can help them along this process, not only before, but also, during and after a tube placement. I am a gastroenterologist, so in our world, we want to use a gut in order to have a G tube. We need to have an in-depth discussion of the indications of the procedure, the goals, the potential complications, care of the appliance by the family, and the care team. So one of the things is that this is an ongoing conversation. So this is something that is not a decision that comes in quickly. Usually there are some steps and there are some conversations that happen along the way where the different team members and the family all participate. When we take into account for G-tube placement, include what is the situation of individual patients, their quality of life, their prognosis, psychosocial factors, and then the information. And all of these, comes together in our decision. One of the things, I apologize. As a gastroenterologist, we want to use the gut. And there are so many different reasons why this makes sense and what it's beneficial to our patients. Looking at the benefits of the G-tube, it can provide long-term nutrition. It provides physiological feeds when you eat and the food is transferred from the mouth, it goes to your stomach. So physiologically, it makes perfect sense. One of the advantages of feeding the GI tract directly is that we maintain the health of those cells and structures, and we preserve the motility, we preserve those digestive hormones. So the integrity of the system, it is preserved. Also, it is very safe. And it is easy to care for. The G-tube, it's going to serve several different purposes. So we think about it for administration of nutrition. However, there are some other things that a G-tube can also do. It can administer fluids, because sometimes taking fluids, it's more of a challenge than consuming calories. And fluids are essential for your body to function. It is also a helpful way to administer medications. Sometimes it is also very, very helpful to help with venting and decompress the stomach. So those are a number of other purposes that can be met with this type of therapy. This is how a G button it's looking on a child, and sometimes that is one of the challenging points. You hear about G tubes, and you don't have a really good sense of what does that truly mean. So that is a picture of one in a young patient, and looking at how it works and how it is placed and how it serves its function and how can stay in place, you can see on this depiction. Here, the tube extends from the abdominal wall into the stomach. It is kept there by a balloon. And then feeds can go and be administered in the stomach. So that's how it works. The actual process of a gastrostomy tube placement can be performed by either a gastroenterologist or a surgeon or a radiologist, and this is based on different institutions, sometimes based on the patient's age. And in the steps leading to placement of a gastrostomy tube, an X-ray to outline the upper digestive system called an upper GI series is obtained, which is something very important ahead of a procedure. One of the things that we need to assess also is, would it be necessary to consider an anti-reflux operation in a patient that is going to undergo gastrostomy tube placement? Talking about placement, as a procedure performed by surgeons, which is how it is performed in our institution, often is performed laparoscopically, which has several different advantages. For one, leads to a faster recovery time. It also allows direct view of the tube placement. It also has the ability also to place a button like the device that I had shown you versus a longer tube. In the pediatric population, typically buttons are more popular. And one of the things is laparoscopically an anti-reflux procedure can also be performed. So definitely there are advantages there. Here I wanted to show you a couple of the low profile buttons that are available, which include the Kimberly-Clark Mickey button or the AMT Mini 1 balloon buttons. They are really low profile, good options for G-tube nutrition in patients. In the process of evaluation for G-tube placement, there are several different steps. So in our institution, assessment by a gastroenterologist takes place. It evaluates history, physical exam, nutrition assessment, the goals of the G-tube placement. Often we order the upper GI series to evaluate the gastrointestinal tract. Also, we assess the potential need for anti-reflux procedures. We also look at the potential need for nutritional rehabilitation ahead of a tube placement. Nutrition is something really important, and poor nutritional status can impair wound healing and recovery from procedures. So this is an important step that sometimes we need to perform in order for a G-tube placement to succeed. Also, we have the opportunity of initiating a discussion about feeding options for patients. Then the next step is meeting surgery in an outpatient visit, where our colleagues discuss the procedure, the timing. Children are typically admitted for at least a couple of days after the procedure. They receive a dose of antibiotics before the tube placement. The placement is laparoscopic under general anesthesia. Typically, in terms of pain management, Tylenol is used. The tube is placed to gravity. The next day is vented, followed by initiation of Pedialyte and then formula feeds. After a couple of days, sutures are removed. During the admission, the families have the opportunity of receiving teaching on the use and care of the G-tube. Also during that time, our care coordination team works with insurance and home care company in order to procure all the equipment and some additional training at home upon departure from the hospital. Typically, the gastro follow-up is done a few weeks, 2 to 4 after discharge, and surgery follow-up is recommended about 8 weeks later for the first change of G-tube, as well as the resizing process. Okay. In terms of issues and concerns with newly placed G tubes, advances in techniques, the ability of doing this with direct visualization, use of antibiotics help decrease immediate issues or complications associated with G-tube placement. Things that we typically watch on patients: redness, swelling, drainage, or fever. We are concerned about any difficulties with the infusion of feeds in the first weeks. Displacement of the tube within the first 8 weeks requires an evaluation in the emergency department to establish that replacing the tube has taken place correctly, while the connection between the abdominal wall and the stomach wall develop. And after that happens, which is usually 8 weeks, then the replacement of the tubes take place at home. With newly changed tubes, the family is advised not to check the amount of water in the balloon quite yet. Along with the buttons, there is a kit that comes with them with several different tools, the extension tubes for bolus feeds, for continuous feeds, a syringe to provide bolus feeds. Then there is a smaller syringe to measure the water in the balloon. So all that comes in, and there's some extra equipment that is procured for home feedings. The care for G tubes actually is a fairly uncomplicated process. The tubes are flushed with room temperature water. You don't apply excessive pressures with flushing. You check the balloon water volume once weekly. Typically, the amount of water is 5 mL or 1 teaspoon. And if low, you add extra to make the 5 mL. You are going to clean the area with soap and water and rotate the buttons on a daily basis. Any other care as advised by your physician. And the most important thing is flushing those well after administrations of feeds and medications. Then the first change is done by the surgeon, usually 8 weeks later. Then those are done every 3 months. And changes also are recommended if there is a malfunction or excessive leakage. Longer term complications are possible. They tend to be easily manageable and include some irritation at the site, drainage, granulation tissue, bacterial infection or cellulitis, yeast, buried if they are not resized, or children gain too much weight, or individuals gain too much weight, or an accidental removal. In terms of feeding administration, there are several different ways that this can be accomplished. There can be bolus feeds that are similar to meal times throughout the course of the day. There is intermittent infusion where patients can have feeds during the course of the day, but they need to run some additional feeds overnight, or continuous feeds where feeding runs on a continuous basis around the clock. Also, feeds can be given through a large syringe that can flow at gravity or with some pressure that works for bolus feeds. Then those can be administered via pump set for a duration. In our G-Tube clinic, a registered dietitian works with me, and your team will have a dietitian that can help determine how much formula, how many fluids are going to be necessary. And if there is ability for oral feeds, we incorporate those in the equation. Also, we can help select the best products based on several different factors. Also can help a product if there are issues with constipation that can help with that. And also to attain adequate nutrition so its children are not overfed or underfed. The formula selection factors, fluid nutrition requirements for history of formula intolerance, the fluids needed, the feeding schedule, and their gastrointestinal functions. There are a lot of different formula options, and that is why the conversation about feeds starts early in the process. There are some patients that may not tolerate those gastric feeds, and we have options for them, which include a GJ tube that can administer feeds a little further down in the GI tract in the small bowel. Those would require continuous administration, and those will need to be replaced by the radiology department. Also, on those, we do not advise rotating those. This is a picture of those that has a gastric port for medications or venting, a J port for the administration of the feeds in the small bowel. To summarize what I have trying to outline on this talk is nutrition support. It's really important in the setting of chronic conditions. Gastrostomy tube feeds can optimize nutrition and quality of life. We understand that it is a very important and a difficult decision. If it's possible, we want children to feed safely orally, but sometimes that may not be possible. This is a team effort ahead, during, and after a tube insertion. And families, in most cases, are just very happy with this decision. This is something that it's very helpful for their children. I want to thank you for inviting me, and I want to acknowledge the assistance of Stacy Settle, my dietitian, who provides some of the slides for this presentation. Thank you.
Dr. Clavel, thank you so much for an incredibly informative session. I know some of our community is already leveraging G-tubes. Some of us are starting to think about what that may look like in the future, and you've really helped define what we should be considering. So thank you.